Dr. Dana DiRenzo, and I'm a member of the Johns Hopkins Arthritis Center. And there were multiple informative sessions at this year's ACR Convergence 2020 with regards to rheumatoid arthritis. The most important and relevant to RA occurred on Monday at 11 a.m. And at that time, the new ACR recommendations for management of RA were presented. These are yet to be published and are not quite finalized, but slated for early 2021. In the review of the guidelines, in terms of overall strategy, they discuss the promotion of a treat to target strategy, which is not necessarily new. The goal is low disease activity over remission, which was a conditional recommendation. The authors then began to specifically discuss pharmacological recommendations. First-line therapy remains methotrexate. Specifically, with regards to methotrexate monotherapy was recommended over combination therapy with other traditional DMARDs or TNFs or non-TNF biologics. Other recommendations included the use of traditional DMARDs without steroids, with reference to adverse events with difficulty tapering. Some other specific recommendations: if on a biologic or a targeted synthetic DMARD, switching to a different class is recommended over staying in the same class of agents, which is new. With regards to tapering, this is recommended, but only for those at goal for at least 6 months, and gradual discontinuation of methotrexate first over gradual discontinuation of biologics or traditional synthetic DMARDs. Some other specific recommendations for which methotrexate is recommended include rheumatoid nodules and stable lung disease. Methotrexate may also be continued in NASH, which is common for those with normal LFTs and normal ultrasound. However, for those with progressive rheumatoid nodules, switching to alternative DMARDs is recommended. Other specific recommendations: the New York Heart Association Class 3 or 4 patients, non-TNF biologics or targeted synthetic DMARDs are preferred over TNF agents. If a patient develops heart failure while on TNF inhibitors, switching from TNF inhibitors is recommended. And in patients with a history of lymphoproliferative disorders, rituximab remains the treatment of choice. Other specifics in which rituximab is recommended include hepatitis B positive patients, in which treatment is recommended prior to starting rituximab, but that is the agent of choice, and hypogammaglobulinemia without infection. And finally, in terms of infection specifically, for patients with previous serious infection, adding or switching DMARDs is recommended over using steroids. For those with high disease activity, adding or switching traditional DMARDs is recommended over using biologics. And specifically in terms of TB, avoiding steroids and use of traditional DMARDs over biologics.